So this all comes back to now this idea of oligometastatic disease. Oligo meaning few, metastatic sites of disease. And Wexelbaum and Hellman really made the concept popular in the mid 1990s. But as far back as the 1930s, surgeons were trying to resect lesions that they could see, metastatic lesions, in the hopes that removing these metastatic lesions could improve the survival of their patients. But what has made it important for us to start really thinking about local therapy in what we call this oligometastatic state, which is a state between earlier stages of disease and then first sites of metastatic disease versus a patient who's developed metastatic disease throughout their body and more globally. And it's really the 2 points that I brought up earlier. One is systemic therapy has gotten better, which means that there's a higher potential likelihood that we find patients in an oligometastatic disease state. And number two, with improved imaging, that also has allowed us to catch metastatic disease at an earlier stage in development. And the third point I would try to make is there was an evolution in our radiation approaches, and one of them was called SBRT, stereotactic body radiation therapy, and it allows us to use high doses of radiation to deliver treatment to very small volumes of disease or relatively small volumes of disease in any part of the body. And it's done in very few treatments, and that's the trick. It can be done in very few treatments. It can lead to killing of cancer and synergize with the systemic therapy, and it's done with limited toxicity. And so it was the evolution of that technology, along with the imaging and better systemic therapy, that has led to more and more studies that are trying to impress upon us the need to use local therapy in the advanced setting.